The invitation, dear colleagues. I'm glad to arrive here this early morning or this late morning. For me, it was an early start in this day, but I arrived very well. And I'm glad to talk about modern techniques in otology. It's a different change to the program, but I think I can connect something to the talk, to this previous talk. At first, I want to speak about balloon dilatation, because we have the middle ear ventilation as a very important fact when we do otology measures. And a lot of discussions are on the way how important the middle ear ventilation is, but nevertheless we know we should focus on it when we do our surgery. But the second question is, how deep is the evidence to this treatment we do with disturbed middle ear ventilation? And that's why I want to speak a little bit about a technique which is nowadays established, and you will see how is the evidence now. What is evidence-based treatment? It's an integration of the research results we got, the clinical expertise we get, and the patient values we collect. So when we speak about middle ear ventilation, we look to the Eustachian tube dysfunction, and we see that the Eustachian tube function has to solve 3 points: to protect, to ventilate, and to drain the middle ear. So we know from our experiences and from our daily work, there are a lot of things done to make it, or to intervene the middle ear and also the Eustachian tube to improve the disturbed function. It starts with only observation, then we can see that we make an active insufflation, we have possible medications, we also do nasal treatments, and we also do surgery to improve the middle ear ventilation or the tympanic, the Eustachian tube function. But we know the problems behind that, not 100% results in one of these measures. So we had a lot of difficulties to define the disturbances. We have a lot of pathologies, different pathologies. We had a lot of tests, and we have to compare these tests. And at the end of all these tests, we had a lot of poor data. And so it is very difficult to define it, and at least it is a low evidence about the Eustachian tube dysfunction. Fortunately, there was a consent group. They established, as you can see here, a clinical presentation and consensus statement, a group of different European countries and North American countries, and they established this consent about Eustachian tube dysfunction. And there was a separation into a dilatory tube dysfunction. The Barrow challenge induced Eustachian tube dysfunction. I had this morning after my short flight, but it's gone. And then we had the third type, the patulous Eustachian tube dysfunction. And when we look to the most important one, the dilatory Eustachian tube dysfunction, we can separate the functional, dynamic dysfunction and the anatomical obstruction. So this is a very important separation and a very good definition, and we can use it for our clinical daily work. But how to measure the disturbances in the Eustachian tube function? And the tympanometry by STV is a very good tool. We usually use the tympanometry, which is only a measurement during the external ear canal. But with this tympanometry, we measure a definite pressure inside the nasal pharynx and control it across the external ear canal. As you can see here, the pressure is given over a nose piece and triggered by swallowing into the nasal pharynx. We can use different pressures, and we can measure the tympanic membrane movements. So we have a pressure sensor inside the external ear canal. And these pressure changes can be compared. And from all these comparisons, it's a very little bit difficult, but I want to come to this point, we find at least an opening latency index. And this index is important because we can use it together with clinical factors like the point of clicking noise after swallowing or after the Valsalva maneuver. And altogether of these factors, we can have a score for evaluating the Eustachian tube function. So the group of Holger Suthoff, friend of mine, they made a pioneer work. They collected all these data, and then they established a balloon dilatation technique. And as you can see, they used the balloon in the membranous, in the cartilaginous part of the Eustachian tube, not in the osseous part, only in the cartilaginous part, to overcome problems in this area. And this balloon, you can see here, is in a dimension of 3 to 20 millimeters and is insufflated by water or by a saline solution, and it's given up with a pressure of 10 bars. It's a really high pressure, so more than a tire in a car. And so this small balloon can dilate to a dimension of 3 to 3 millimeters in diameter. And this is a very short dilatation, but it gives a bit pressure inside of this small canal. And it stays there for 2 minutes, and then it's taken out. This is the measure. Here you see it on a scheme. You can do it via a special canal, a metallic canal, and you can control it endoscopically through the other ear nose canal or through one nose canal with a 0 or 70-degree optic. You can also use it in children. It is a little bit more tricky because the nose and the ear canals are more narrow, so you can also use it by a pharyngeal access. What you need is a catheter, and this tube with the balloon at the end is wired through this catheter, and there are different shapes available, 30, 45, and 70 degrees, depending on the specific anatomy of the patient. And under endoscopic control, these catheters are introduced into the pharyngeal ostium of the Eustachian tube, and through this device, the balloon is introduced and then insufflated by saline solution. So the question is, how effective are these treatments? And this pioneer group has collected till 2015, in a time of 4 to 5 years, 622 cases, and they saw, as you can see here, a long-term result of this Eustachian tube with a success rate of around about 70%. Okay, you can say it's a small group all in all, but here you see what they use. They use these scores I told you, and by the time, after 3 years, the scores are still in a very good shape after these treatments. But this measure spread it all over the world. A lot of centers use this, and here you see that a multicenter study was introduced, and it was published in 2017 in Laryngoscope, and you can see it in the yellow, the tympanogram normalized in 62% after 24 weeks, and it stabilized, and also the tube dysfunction questionnaire was also showed an improvement of 56.2%, and it was much better than to the comparison group. So there was evidence level 1B. And again, another trial was done. It is published in 2018 in the Otology, Neuro-Otology, another group prospective multicenter randomized controlled trial. And you see there was a persistent improvement also by a questionnaire controlled and also multi-centered controlled study. And also in 2018, another group from the Netherlands, 2 independent groups, controlled the literature by a systematic review, and they saw that the 36 verve articles were compared, and you could see all current studies suggest that the balloon dilatation technique is worth in the treatment of Eustachian tube dysfunction. So at the end, we can conclude when we look to the balloon dilatation technique that is a safe method, and nowadays we have 92,000 cases controlled in the literature about this technique, and so the evidence is there, and we can say it's a safe, effective, and durable treatment. But nevertheless, another or more randomized controlled studies are necessary. Okay, it's a thing we should think about more and more, but it can be introduced into the otology surgery, and I think it's worth to discuss about this. Now I want to come to the next modern technique in ear surgery. You heard in the previous presentations something, and I want to bring a bit of my experience to this point. When we look a little bit back, it started round about 40 years ago when Ohnsorge in Würzburg, it's a head and neck clinic and very important in otology surgery. They introduced first time a so-called ototympanoscope, and the Karl Storz company produced a very small scope, but it was not very usable at that time. In the 80s, Thomasin and in the same time McKinnon, they did it parallel. They first used the endoscope systematically in second look operations, that means in the control after cholesteatoma surgery. And Tarabici was the first who made the first case series in otology endoscopic surgery, and they showed the first series with 38 patients, and then later on they came out with a series of 165 patients in the late 90s. Together with one colleague, I published in 1998 a small book by the Karl Storz company, and we wrote about the usefulness of scopes in the diagnostics of otologic diseases. Okay, I think we heard something about the worth of endoscopes in the diagnostics of the tympanic membrane and the middle ear. And here you can see, excuse me, this is a epitympanic cholesteatoma, and with a suction tube you can control this epitympanic perforation, and we have a full overview across all borders of the tympanic membrane, and you can also look into the small perforation, and with a special instrument you can also look a little bit around the corner and see the perforation inside. So diagnostics is a very important tool. The second point is we can use the endoscopes in secondary endoscopic ear surgery. It's an additional use of endoscopes in microsurgery of cholesteatoma. This was established in the 90s, and I think this is a very important thing we should speak about. And the third is the primary use of endoscopes in ear surgery. You heard something in the previous presentation with wonderful pictures, wonderful videos, and you could get a very good impression about this. And this means exclusively use of scopes as a substitute of microscopes. When we look to this primary endoscopic surgery, we have an access via the external ear canal. We have no soft tissue damage. We have a very short tympanomeatal flap to open the middle ear. And the endoscope stays mainly outside of the middle ear, but we have the wide angle view. We can see niches and also corners, and we can look around the corner. And so we can also look around the curvature of the external ear canal and have a very good overview. The point is that we need some special curved instruments because we have these wide angles, and that's why sometimes it's necessary that we use these long curved instrument. But nevertheless, we shouldn't forget there are some disadvantages. We have single-hand performed surgery. We have to hold the endoscope on the left hand usually and use the instrument in the other hand. So suction is a problem sometimes. So the double-handed procedure is not possible usually. We have no stereoscopic view. We have only a wide angle view as a big advantage, but no stereoscopic view. And the point is, when we have a blood drop or mucus on our lens, we have to clean it. And when we have a bleeding or we have a maneuver, it is very easy that the lens is obscured. And that's why most of the ear surgeons say a sterile trained microscope should always be allocated during the surgery of the ear. And another point is very important. You have seen wonderful pictures. And I'm not sure that you have seen and also seen exactly what's there in the anatomy. It's because of the wide angle. And it's likely that a new anatomical nomenclature has to be introduced because we have a new view into the middle ear. And some groups start with establishing a new view to the anatomy of the middle ear by the endoscope. And with this new view into the middle ear, we can establish pathways for the spread of the cholesteatoma. For instance, from the upper to the lower hypertympanon, you see the red arrow there. And we see there are some special structures we usually don't see with the microscope. And so we have to focus on the anatomy, especially on the view of the endoscope. Okay, here you see again the secondary endoscopic ear surgery. And this is a way how we can use angled scopes during the microsurgery, especially in the cholesteatoma and the extended cholesteatoma surgery. It can be used for preservation of bony structures, especially the lateral attic wall and the pneumatized structures, which are usually not visible, can be visualized with the scopes. Here you see the situation. The left-hand side is the microscopic view. The right-hand side is the scope, the endoscope. The point is, you see only a 2D scope, a 2D view by the microscope. I cannot show you the real three-dimensional view. But with the scope, you have the original view I have during the surgery. And here is a cholesteatoma. You see the antrum, and there's a cholesteatoma sac. And with two hands, it is possible to maneuver and release the cholesteatoma sac. And on the right-hand side, you see you can have a very good insight, but all the maneuvers there are a little bit limited because you have to hold the scope and you have to maybe suck and to change the instruments all the time. Here, it's the view in the middle ear. It's the middle ear is opened, and on the left-hand side, you see the resection of the malleus head. And then on the right-hand side, you see the endoscopic insight into the middle ear after resection of a big cholesteatoma from the middle ear. Left-hand side, you see the middle ear, the mastoid, and the view into the attitus ad antrum. And so there is a limited insight, and with the endoscope, you have a very nice overview in the middle ear. The same situation here. A little bit forward. Now we control the middle ear. We can look also into the orificium of the tube, and we can oversee the area of the facial nerve and also the attic. And then we can change to the posterior part with the scope and can look into the antrum and the epitympanon, and then we can use an instrument from the middle ear side and can see there is the movable remnant of the malleus, and then we see there is some cholesteatoma behind, and this is possible to resect it and to remove it. So these are the advantages where we can combine the microscopic and endoscopic way of doing otologic surgery. And this is cochlear implantation. And you see we have a perfect view into the epitympanon and the antrum with the endoscope. Perfect view, high resolution. But when we do a posterior tympanotomy, we need two hands. We need a drill, we need a suction, and for this we need a microscope. And we have also good insights, but we need a very good focus, but we have nevertheless good possibilities to resect, good options to resect bony small particles. And then we can also use the microscope to look a bit in the areas, and with focusing, we also can get quite good information, but it's a bit more impressive by the microscope, especially in deep and narrow parts. So now the posterior tympanotomy is opened more and more, and so we can get an insight into the round window niche. Now, this is perfectly shown by the endoscope. We can see details which we cannot reach with our microscope. But the maneuvers in there are impossible with the endoscopic view. So for a control, it's perfect. For the maneuvers, it's limited. So you see the round window here. And the next step is to open the round window done under microscopic view, but this is only at one eye. In the real situation, you have two eyes. That means a stereoscopic view, and then you see it better than I can show it with this video. Here, the incision of the round window, and then the insertion of the electrode. And you can see this white spot, which is the limit of the introduction of this. And now we can use the scope and go into this niche and control the insertion and the placement of the electrode inside of the round window niche. I think this is a very good comparison of these two measures in the otoscopic surgery. When we look to the literature, there is a paper printed last year, and there was a group, they compared 28 patients with microscope and endoscopic myringoplasty. And they showed that there is a time difference, 37 minutes in endoscopic surgery and 107 minutes in microscopic surgery. And they followed that the endoscopic surgery is 2 times faster in comparison to the microscope. I would say this to this study. Another point is, and I think this is very important, and we heard that before, when we do more and more endoscopic surgery, especially in the middle ear area, we have a learning curve. And after a lot of surgeries, we will be faster and we'll be safer and more precise. This is true, and so this short and small study shows us this. In conclusion of my short talk, I want to say, in principles, the endoscopic surgery is similar to the microscopic ear surgery. We can maybe preserve something of the ossicular change in cholesteatoma surgery, maybe, more likely. We have less damages of the chorda tympani, especially in the middle ear area, we have advantages. And we have a better visibility of the isthmus tympani and all the other ventilation pathways. So we can say there is no complete substitute for the traditional use of the microscope. However, an interesting adjunct to microscopic ear surgery. And fortunately, the industry is coming to this point, and now the first microscopes are produced in connections with the endoscopes, so that all the techniques is now really combined. And this is maybe the future. Thank you very much.